Professor at MAMC and Loknaik Hospital, New Delhi. Her area of special interest are fibroscopy and difficult airway management, BLS and ACLS, pediatric anesthesia, anesthesia for bariatric surgery, teaching and training, medical oxygen infrastructure, logistics, and management. We welcome you, ma'am. As a moderator for this session, we have Dr. Tina Khurana. Ma'am is Associate Professor in the Department of Anesthesiology at ABBIMS and Dr. RML Hospital. And our areas of keen interest are airway management, ALS, and BLS instructor. The case will be presented by our final year postgraduate student, Dr. Sharma. Over to you, ma'am, for the proceedings of the session.
Good afternoon, Prisha. Good afternoon. So you can start telling us about your case.
Yes, ma'am. Ma'am, am I audible, ma'am?
Yes, please.
You are audible.
Reena Kumari, 28-year-old female, a resident of Rajendra Nagar, Delhi, homemaker by occupation of low socioeconomic status, was posted by Burns and Plastic Department for neck contracture release and split skin grafting surgery from lower limb. She came with the complaints of she presented with postbone scarring at lower part of chin, front, and both sides of neck for 1.5 years. She has grossly restricted neck movements with inability to look upwards and in either direction from the last 1.5 years. Mouth opening is limited for the same duration. A patient gives history of thermal burn injury due to gas leak while cooking in kitchen 2 years ago. She was immediately removed from site by her relatives and wrapped in a blanket and taken to a nearby hospital. Patient was conscious all throughout the incident. She has no history of singed hair, blackish sputum, hoarseness of voice, difficulty in breathing, noisy breathing at the time of burn. According to the documents available, patient sustained a 3rd-degree burn of lower face, whole neck and front side of the chest with involvement of around 12% of total body surface area. Patient was conservatively managed with regular dressing, fluids, and antibiotic in ward for a month. There was no history of ICU admission. Contracture formation in the neck started after 4 months of burn. It was gradual in onset and progressive in nature, leading to the present stage. She is not eating well and has lost of weight around 6 kg since burn injury. She has difficulty in sleeping and sleeps in lateral position with a pillow under her neck. At present, she has no history of fever, cough, or cold. She has no history of snoring or difficulty in swallowing. There is no history of change in voice, epistaxis, reflux, or regurgitation, and she gives no history of psychiatric illness, depression, or anxiety. In her past history, she has no history of diabetes, hypertension, heart disease, bronchial asthma, tuberculosis, epilepsy, or psychiatric illness. She has no history of trauma, blood transfusion, drug allergies, radiation, exposure neck in the past. She has no history of hospitalization except for the burn incident. She consumes a mixed diet. The bowel bladder habits are normal. She has no addictions and she is educated till 12th class. She is married for 9 years with 2 children, 8 years and 5 years old boy and a girl respectively. Both were full-term vaginal home deliveries. Her LMP is 27th November. On examining the patient, examination was done after taking consent from the patient. It was performed after making her comfortable with a female attendant present with her. Examination was done in the sitting position. Patient was conscious, oriented to time, place, and person, and was cooperative. Obvious burn contracture was seen in the front of the neck. Fixed flexion deformity on neck observed. There was pallor present. There was no cyanosis, clubbing, icterus, pedal edema, or lymphadenopathy present. Peripheral veins are accessible. JVP could not be assessed because of the neck contracture. Her weight is 50 kg, height is 165 centimeter, and BMI is 20.6 kg per centimeter square. The pulse, the hemodynamic parameters of the patient were: the pulse was 90 per minute. It was regular, good in volume, normal in character, no radiofemoral delay, or peripheral pulses were palpable. The blood pressure of the patient was 120 by 70 mmHg, recorded in the upper arm in sitting position. Respiratory rate was 14 per minute, regular and thoraco-abdominal. The saturation was 98% on room air. The patient was afebrile on touch. On local examination, the burn area involved approximately 12% body surface area. The patient's nostrils appeared normal. Both angle of mouth are scarred. The lower lip is everted. Hypopigmentation noted over the neck, chest among scar tissue. Contracture was seen extending from the symphysis menti to anterior chest up to the nipple line, laterally from the angle of the mandible to anterior chest. Fixed flexion deformity is present in the neck. Forward gaze is maintained. Arm and hands are free from burn contracture. Thyroid, cricoid, and cricothyroid membrane and trachea could not be assessed. On airway examinations, the bilateral nares were patent, right more than left, and there was no obvious growth. On examining the mouth, we found that the inter-incisor gap was of 2 cm, no loose tooth, artificial or buck teeth seen. There was no high arched palate. The modified Mallampati grade was 4. On examining the temporomandibular joint, we observed that the upper lip bite test was grade 2, the Calder test was grade 2, and the finger test showed that there was no crepitus, click, or grinding movement. On examining the neck, we found that the thyromental, hyomental, and sternomental distance could not be measured due to the scar tissue. Length and the circumference of the neck also could not be measured as the landmarks could not be palpated properly. Fixed flexion deformity was present in the neck. Patient was unable to touch her manubrium sterni with her chin. Neck range of movements, flexion is restricted with only slight extension. 2-scale test was performed and the angulation was only 10 degrees. The Delicken's sign showed that the finger at the chin remained lower than the finger at the occipital tuberosity as the patient could not extend her head. On respiratory system examination, on inspection, we find that the nostrils were normal. There was no visible pulsation, venous prominences, ulcers, or mass. The chest movements were bilaterally equal. The patient was not using accessory muscle per respiration. The respiratory rate was 14 per minute, regular and thoraco-abdominal. There was no bony deformity. On palpation, the inspection findings were confirmed. There was no tenderness, normal temperature, and the vocal firmitus was bilateral equal. On percussion,
what all other systems have you examined systemically?
Ma'am, I have examined the cardiovascular system, I've examined the abdominal system and the CNS examination.
Any positive finding in any of the systems?
No, ma'am, there were no positive findings.
So I would like you to summarize your case now and
ma'am,
tell us the diagnosis.
Yes, ma'am. Reena is a 28-year-old female with no associated comorbidities. She was presented with the post-burn contracture involving lower face, neck, and anterior chest, leading to restriction of neck extension and decreased mouth opening since past 1.5 years.
Okay, so this is a case which is the patient had sustained burns 1.5 years ago. Okay,
ma'am, so, she sustained burns 2 years ago. The contracture formation started 1.5 years.
2 years. All right. So what all in such a patient who comes for any surgical procedure under anesthesia 2 years after such burns, which is involving the airway? Just gross problems, let us know.
Ma'am, I'm sorry, your voice broke in between. I did not get your question, ma'am.
Suppose this patient who has got a 2 years old burn history and she has a contracture neck.
Yes.
She is presenting for any surgical procedure under anesthesia to you. So what all common problems you would have as an anesthetist?
Ma'am, since she is coming after burns and she has developed a contracture in her neck, so it is a anticipated difficult airway. So, ma'am, I will be having difficulty with the various parameters in airway, such as, ma'am, I will have difficulty in mask ventilation. I will have difficulty in supraglottic airway device insertion. I will have a difficulty in laryngoscopy, intubation, as well as in front of neck access, surgical front of neck access.
Okay, airway. Okay, airway. Trisha, airway. Trisha, Trisha, am I audible to you?
Yes, ma'am. Yes, ma'am. Now you are, ma'am.
Can you hear me?
Yes, ma'am.
Yes. So I'm saying that one of the problems will be her difficult airway. What other major problems you will have in such a patient? Because she is a case of burns sustained 2 years ago. What all problems can such a patient have? For example, nutrition, she may not be eating well. She might be anemic. What else?
Ma'am, there may be burns on her limbs, ma'am, because of which there will be a difficult IV access. Also, ma'am, there will be difficulty in applying monitors to this patient if the limbs are involved, ma'am.
Okay. So if nutritionally patient is weak, so what are you concerned as an anesthetist? What are her proteins like?
Ma'am,
which protein I'm talking about?
Ma'am, the complete blood count, ma'am, patient will be anemic if she is malnourished. So her hemoglobin levels will be
albumin levels can be low. Albumin levels can be low in this patient.
Yes, ma'am.
Besides hemoglobin, yes, she might be anemic. Albumin levels can be low.
Yes, ma'am. Yes, ma'am.
Okay, so what is the importance of albumin to an anesthetist?
Ma'am, if the albumin levels are low, so all the anesthetic drugs that we will be administering to the patient, there will be more free drug available, ma'am. There will be less protein binding of the drug.
Okay, so that's the importance of albumin. So now you have taken history examination, you have done, and suppose this patient is now posted for contracture release with split schedule.
Yes, ma'am.
She can't hear me. Audio. Can you hear me, Trisha?
Yes, ma'am. Yes, ma'am. I can hear you now.
What all investigations would you order if such a patient is posted for contracture release and grafting?
Ma'am, I'd like to order a complete blood count for this patient. Ma'am, I will also order serum electrolytes, ma'am, and I'd like to order urine routine microscopic examination. I'll order X-ray cervical lateral and apial view, ma'am. Cervical sign, lateral and apial view.
So what's the importance of electrolyte in this patient? Any special reason you would like to order for electrolytes?
Ma'am, since she's a burn patient, ma'am, and I want to decide which neuromuscular blocking agent I want to use. So, ma'am, in case I want to use succinyl choline. It can cause dangerous hyperkalemia if it is used within 48 hours or 48 hours to 2 years of burn injury, ma'am. So, I want to see this.
Why does choline do that? What is the problem?
Ma'am, there is increased sensitivity of the receptors to succinyl choline because there is upregulation of the post-junctional receptors, and this is associated with the extracellular movement of the potassium, so resulting in hyperkalemia.
So,
Ma'am, I'm so sorry. Voice is, ma'am, not.
And you use choline in your patient? She's an old case now. More than 2 years have passed.
Ma'am, my case is exactly 2 years, ma'am. So it is borderline, ma'am. I'd like to avoid it, ma'am.
Okay. All right. How much potassium is released once you use choline normally in a normal patient?
Ma'am, I'm not sure, ma'am.
It's 0.5 millimoles. Okay.
Okay.
All right. So now you have taken history examination, you have reached a diagnosis now, and you know the surgical procedure that the patient has to undergo. How will you plan your anesthesia? Are you aware of the, does your patient qualify to have a difficult airway? Yes or no?
Yes, ma'am. My patient qualifies to have a difficult airway.
She
Ma'am,
can't
there are
hear me. So, are you aware of the ASA task force difficult airway algorithm?
yes,
Can you
ma'am.
project that? I think you have a slide there.
Yes, ma'am. I do, ma'am. This is my algorithm. Ma'am, ma'am, is it
We can't see your
ma'am, is it visible now?
yes, come to the slide, earlier slide. Yes. So this is the difficult airway algorithm, which will help you in any patient with difficult airway. It will help you to decide how to go about it.
Yes,
So what is the first point? You have to assess the likelihood and the clinical impact of your basic
Management problems.
problems. Okay, we will talk earlier slide, please.
Ma'am.
The earlier slide only. A slide before this. The second point in the algorithm is that you have to deliver oxygen throughout your airway management.
Yes.
Then third is you have whatever option you decide, you have to see the merits and feasibility of that option, whether, for example, you want to keep your patient awake, you want to paralyze your patient. Okay, that's the third point. And fourth point, based on your 1, 2, 3 assessment, you reach a primary plan as well as your alternative plans, because there are chances that your primary plan may fail in any circumstances. So next slide, just show us the next slide. So when you decide, the first thing that you do is you have to decide the type and the severity of difficulty in your airway management at any stage. That means right from ensuring patient's cooperation till you extubate the trachea of the patient and post-operative, post-extubation airway management. Okay.
Yes.
So first is, can you read these problems for us?
Yes.
What is the first problem you have to see for?
Ma'am, difficulty with patient cooperation and consent.
Okay. What about your patient? In your case,
my patient
cooperative?
Cooperation and consent. Yes, ma'am.
Okay. So consented patient and cooperative patient. Next, difficult mask ventilation.
Yes, ma'am. Yeah. My patient has my patient has predictors for difficult mask ventilation. And
what are those? Why the mask ventilation is difficult in your patient?
Ma'am, because in my patient, ma'am, when I performed the airway examination, I saw that in the upper lip bite test, as well as the Calder's test, it was grade 2. So the temporal mandibular joint will not be subluxated, and it is vital for our adequate mask ventilation for us to be able to subluxate the temporomandibular joint or to lift it, ma'am. So in this patient, I won't be able to.
Extension is also limited. The extension is also limited. Okay. All right. Next step.
Difficult supraglottic air.
Any difficulty in use of supraglottic? Any difficulty?
Yes, ma'am. There will be a difficulty because the mouth opening in my patient is only 2 centimeters, ma'am. So it will be very difficult for me to introduce it.
Okay. What about next? Difficult laryngoscopy?
Ma'am, in difficult laryngoscopy, again, the mouth opening is 2 centimeter. Also, I will not be able to extend the joint because at the range of movement at the AO joint is only 10 degree, as I had confirmed in my airway examination. Also, ma'am, my Malampati grade is grade 4, so it will result in difficulty in laryngoscopy.
So similarly, the intubation is also difficult. What about
Yes.
the front of neck axis? Is it difficult or easy in your
Yes,
case?
ma'am. Yeah, ma'am, it will be difficult because she has a contracture and it is a fixed flexion deformity which is present in the front of the neck, because of which I will not be able to appreciate the landmarks and resulting in difficulty in surgical airway access.
So based on this assessment, what is your now plan of anesthesia?
Ma'am, based
How
on
do you
this,
want to anesthetize this patient?
now, based on this, I would like to perform a awake nasotracheal intubation via the fiber optic, followed by general anesthesia with controlled ventilation, ma'am.
Okay, so you want to keep your patient awake and you want to do a nasal fiber optic guided intubation followed by general anesthesia and controlled ventilation. Okay, good. That's your plan A. But as the algorithm says,
Yes.
that along with plan A, we must have plan B and C. So can you just name your plans, the alternative plans? We'll discuss them later. What could be your plan B or plan C?
Yes, ma'am, plan B, I will again do a awake supraglottic airway device insertion, ma'am. Ma'am, if that
Okay.
fails, then I would like to try I will induce the patient with injection ketamine and ask the patient to ask the surgeons to release the contracture and then try to introduce my laryngoscope and followed by intubation.
Okay. Okay. So let's come back to your primary plan of doing an awake fiber optic intubation. So the patient is posted for her surgery tomorrow morning at 9 a.m. So on the evening, a day prior, you visit your patient. What all will you do for your patient at that time?
Ma'am, I will review the PAC. I'll ask for any fresh complaints. If she has any fresh complaints, I will explain the procedure to the patient. After I have explained the procedure and won her confidence, ma'am, I'll take a written informed consent for the procedure. I will also like to take a written informed consent for emergency tracheostomy. I will instruct her to not eat 6 hours prior to the surgery and not take any clear fluids 2 hours prior to the surgery. I will prescribe her a tablet pantoprazole of 40 mg in the morning of the surgery, ma'am.
Okay.
Ma'am, also I would like to
pantoprazole. What is the role of pantoprazole to this patient, or that is done routinely for all the patients preoperatively?
Ma'am, for this, it is also important for this patient, ma'am, because my plan B is to put a supraglottic airway device, ma'am. So I want to give her anti-aspiration prophylaxis, ma'am. So that is why I want to give pantoprazole to this patient.
Okay, whatever the device, every patient of difficult airway should receive aspiration prophylaxis in form of an antacid and a prokinetic agent. So that's what you said. Okay. So what else would you write for the pre-op orders? Anything else which should be written in the pre-operative order?
Yes, ma'am. Ma'am, I also want to inform the surgeons to take this as the first case the next day. I want them to arrange for an ICU bed and a mechanical ventilator. Also, ma'am, I want the ENT surgeon for standby, ma'am.
If you, on your visit, you find that the patient is extremely anxious, so what about giving her a mild anxiolytic?
Yes, ma'am, I can give her a mild anxiolytic. Ma'am, I'll give her a tablet, alprazolam, 0.25 mg, ma'am.
Okay, as long as the anxiolytic is a mild one, the dose is appropriate, which you think will not compromise her respiration or upper airway in any way, you can administer. Otherwise, the best part in difficult airway is that you can use non-pharmacological means of allaying the anxiety of the patient. You must counsel her, explain the procedure and allay her anxiety. That's the best way of doing things. Okay, now next day, the patient has reached the operation theater and you are there. How will you prepare your OT? How will you prepare your patient?
Ma'am, on the morning of the surgery, I'll first prepare my OT. I will check my defibrillator. I will check my anesthesia machine. I will check my emergency. I will prepare my emergency drug and check my emergency instruments. I will prepare my difficult airway trolley. And I will prepare my fiber optic. And after preparing my OT in the pre-operative area, I will again explain the procedure to the patient, apply monitors to the patient. I will apply non-invasive BP cuff. I will apply pulse oximetry, saturation probe, and ECG to the patient. And after applying the ECG to the patient, ma'am, I will explain the procedure to the patient, and then I will start to topicalize her airway.
Okay, would you like to secure an IV before you start topicalizing the airway of the patient?
Yes, ma'am. I will secure an
IV before we start topicalize. So, how will you topicalize the upper airway? What methods?
Ma'am, I'm sorry, ma'am. Before I start with the topicalization, I would also like to give her an injection of glycopyrrolate, 0.2 mg, ma'am, before I start my topicalization.
Before you start topicalization, you may like to administer some drugs, IV. Okay. So, what all drugs you said? Glycopyrrolate. What is the function of glycopyrrolate?
Ma'am,
why do you want to develop?
Ma'am, it is an anti-sialagogue. It will decrease the secretions, which will help me to have a better view while I'm performing my fiber optic intubation.
Okay, it will keep the airway dry. It will help the local anesthetic to act in a better way. And plus, it will keep your vision clear while administering. So, is IV better or intramuscular glycopyrrolate for anti-sialagogue action?
Ma'am, I will prefer intramuscular, ma'am.
Yes. So, for intramuscular, it should be administered at least 30 to 45 minutes prior to your procedure. Okay. All right. So, what all areas would you like to topicalize or anesthetize?
Ma'am, I will. Ma'am, I will start with nebulizing my patient. I will nebulize my patient with 4 ml or 4% lignocaine.
What all areas would you like to anesthetize? Nasal cavity?
Yes, ma'am. I want to anesthetize the nasal cavity. I want to anesthetize the oral cavity, the posterior pharyngeal wall, the hypopharynx, and that's it.
So, what is the nerve supply, the major nerve supply of the nasal cavity?
Ma'am, the nasal cavity, postero-inferiorly, it is supplied by the greater palatine nerve and greater palatine nerve and the sphenopalatine nerve.
All the branches of the trigeminal nerve. Okay.
Yes,
what about the oral cavity? Which is the major nerve supplying the
major nerve supply is the the posterior 1/3 of the oral cavity is supplied by the glossopharyngeal nerve. The anterior 2/3 is again supplied by the trigeminal nerve.
Okay. The supraglottic area supplied by?
Ma'am, the supraglottic area is supplied by the internal laryngeal nerve, which is a branch of the superior laryngeal nerve, which is a branch of vagus nerve.
And what about the infraglottic area?
It is supplied by the recurrent laryngeal nerve.
Recurrent laryngeal. Okay, now start. How will you topicalize? You were talking about nebulization. How will you nebulize your patient?
Ma'am, I will take 4 ml of 4% lignocaine, and I'll ask the patient to sit. I'll ask the patient to sit upright and apply the nebulization mask on the patient, and ask the patient to take breaths from the nose and take it out from the mouth. And for about 15 to 20 minutes, I will keep the nebulization at oxygen rate of 6 to 8 liters per minute. After nebulization, I will like to nebulize my nasal cavity, and I'll nebulize my nasal cavity by taking 2% lignocaine jelly in a lubricated gloved finger, in my lubricated small finger, and then I will lubricate both the nostrils, and whichever is more patent, I will I will make a note of it so that I can put my the fiber optic intra. Then oral cavity, ma'am, I will like to use 2 ml of 2%.
What is the importance of, preparing the nasal cavity? What all will you do to the nasal cavity? Besides lubricating and anesthetizing, there's something else you need to do?
Ma'am, dilatation. I would like to dilate my nasal cavity, ma'am, so that the fiber optic can pass through easily.
Dilate, what else? What else?
And
What
also,
else?
ma'am, I'd like
So
to
you
use
also need to vasoconstrict your nasal cavity.
xylometazoline. Yes, ma'am. I'll also like to use a 0.1% xylometazoline drops, 2 to 3 drops in each nostril.
So you will vasoconstrict, lubricate, dilate, and anesthetize your nasal cavity, which may be the passage for your primary device, and it can be a passage for your What else would you do?
Ma'am, then I like to anesthetize my oral cavity. I'll ask the patient to gargle with 2% of 2 ml viscous lignocaine gargle. I'll ask the patient to gargle and spit it out, and I'll ask him to do it twice. After I've anesthetized the oral cavity, I'd like to anesthetize the posterior pharyngeal wall. I'll use a 10% lignocaine spray and spray twice on the either side. After this, I will take the patient to the OT and
Okay, just a minute. So one thing, just 2 sprays in the oropharyngeal cavity is not enough to anesthetize. You need more than 5, 6. Okay. So now you have used your local anesthetic for nebulization in the nasal cavity, gargles, and for your sprays also. So what is the safe limit of the local anesthetic that you are likely to use for topicalization? Lignocaine, what's the safe dose for topicalization?
For topicalization, the maximum dose that we can give is 9 mg per kg of lignocaine.
So your patient is 50 kilograms. So what is the safe dose, safe limit for this patient?
So, ma'am, it should be 450 mg.
Okay, 450 milligrams. So what you should do is that for each step, you should, calculate how much lignocaine you will be using and then add all that. Okay.
Yes.
So what is the dose for lignocaine, plain lignocaine and with adrenaline that we otherwise use, not for topicalization? What is the dose there?
Ma'am, for plain lignocaine, we can use 3 mg per kg, and with adrenaline, ma'am, it is 7 mg per kg.
Why do you think the dose is higher for topicalization and yet the patients do not develop toxicity, isn't it? The plasma concentrations never reach toxic levels. Why does it happen?
Ma'am, because from the mucosa, ma'am, only 25% of it is absorbed, ma'am. So the entire dose that we are administering is not absorbed systemically, ma'am.
Okay, because the buffering capacity of the mucosa is very less. So the entire doesn't is not absorbed, and much of the drug what you use for topicalization is suctioned away, a patient swallows. In nebulization, it is only during inspiration that the drug is going to the patient. So such high levels are never reached. Still, you must always confine to 9 milligrams per kg body weight. Okay, what else? What else will you do?
Ma'am, now
topicalization finished?
Yes, ma'am.
Anything else would you like to use before or during your fibroscopy?
Yes, ma'am. I want to do a spray as you go method, ma'am, in which I will attach a 10 ml syringe to the working port of the fiber optic. I'll take 1 ml of 2% lignocaine and 9 ml of air. And while after introducing the fiber optic, once I recognize or once I localize, once I see the epiglottis, I will spray once. Then I will move forward.
Wait.
Yes.
So now, before you start the fibroscopy, I hope you have attached all the monitors, IV line is in any drug, anything, any other drug would you like to administer?
Yes, ma'am. I want to give mild sedation to my patient, ma'am. So I'll give injection midazolam.
What do you mean by mild sedation? What do you mean by mild sedation?
Ma'am, I want to sedate the patient in such a manner that the patient is spontaneously breathing as well as responding to my commands. So I will give injection midazolam 0.5 mg and injection fentanyl 20 mics.
Okay. So as we know, the DAS has given very nicely in the awake tracheal intubation guidelines. So what is the word that he uses? STOP, stop. Sedate, topicalize, oxygenate, and perform. So sedation should never be, substitute for inadequate topicalization. The level of sedation should be such that you're able to communicate with the patient at all times. Okay, so you have given sedation. Then which kind of tube would you like to use for the intubation?
Ma'am, I
Any
would like to
particular
use
type?
ma'am, I would like to use the cuffed PVC tube of size 7 for this patient, ma'am.
Okay. All right. So as you have started your fibroscopy, your cardiodynamics and every other parameter, the patient's saturation starts falling. Can it happen? Awake patient
Yes,
who is
ma'am.
spontaneously breathing, can his or her saturation start
Ma'am.
falling?
Yes,
So
ma'am.
how can you circumvent this problem?
Ma'am, I will also, before starting my fiber optic, ma'am, I will like to supplement, I will like to para-oxygenate my patient with nasal prongs at oxygen level of 10 to 15 liters per minute.
With the nasal, you cannot use such high flows. It will be very uncomfortable for the patient. Okay. So
Okay.
it is better that you use oxygen through the side port of the working channel of your fibroscope. One of the ports can be used to oxygenate. Okay, that has additional advantage that it will blow away the secretions from your target point also, besides oxygenating your patient also. So you must, as the number 2 point in ASA algorithm is that you must ensure supplemental oxygen
Yes, ma'am.
at all points of airway. So we will supplement local anesthetic on the epiglottis and before just entering into the trachea onto the vocal cords. Then we identify the trachea by seeing the, how do you identify
Carina and the tracheal rings, ma'am.
the trachea? Tracheal ring. Okay, so the tube is in, you have taken out your fibroscope. Thereafter, what will you do? You will connect your patient to the breathing circuit and you will reconfirm the placement of the tube by capnograph and bilateral chest movements. Okay, so thereafter, what will you do? What will you do after this?
Ma'am, then ma'am, I will.
The airway is secured.
Yes, ma'am.
Okay,
Ma'am,
then
I will give my induction agents, ma'am. Then I will completely anesthetize the patient. I'll give my full dose of induction agents, followed by I will give injection propofol. For this patient, I'll give 100 mg of injection propofol, followed by injection vecuronium, 5 mg. And once I have paralyzed and anesthetized the patient, I will hand over the patient to the surgeon to start their procedure.
okay. So you have used various methods for topicalization of the airway. What is the role of various nerve blocks? They are extremely effective, isn't it?
Yes, ma'am.
So what about blocks in your patient?
Ma'am, in my patient, it will be very difficult to give blocks, ma'am, because she has a fixed flexion deformity in front of her neck, and the anatomical landmarks will not at all be appreciable. But otherwise, ma'am, in other cases, we can use blocks for topicalization.
What all blocks are used to topicalize the airway? I mean, to anesthetize the airway. What all blocks can be given?
Ma'am,
Just
we can. Yeah, ma'am, we can use a laryngeal block, and then ma'am, we can use a recurrent laryngeal block and a glossopharyngeal nerve block.
Recurrent laryngeal nerve block is never given. You give a translaryngeal, okay? So
Yes.
you can give glossopharyngeal nerve block, superior laryngeal nerve block, and a translaryngeal
Yes,
nerve block
superior.
for infraglottic area. Okay. So the surgeon, what is the procedure? The surgeon will release the contracture and take the split skin graft from the lower limbs and place it on the neck and suture it.
Yes, ma'am.
So how does the patient look towards the end of the surgery? When the surgeon is through with his surgery, how does the patient look?
Patient
I hope
has
you have seen.
Yes, ma'am, I have, ma'am. Ma'am, patient has a massive dressing in the front of her neck, ma'am. So,
There's a huge dressing.
Yes, ma'am.
Okay. So, what about extubation? Will extubation, are you anticipating any problem in extubation? Should you be planning your extubation? Yes.
Yes, ma'am.
So,
I am
what kind of extubation will it be? What kind of extubation will it be?
Ma'am, I am anticipating it to be a difficult extubation because since there is such a massive dressing in front of the neck, it will be very difficult for me to hold the mask over the patient. So, ma'am, I will, for such a patient, I will try to perform, I will perform a wake intubation.
So according to your, I hope you are familiar. So are you aware about the DAS extubation guidelines?
Yes, ma'am.
Okay. So he has categorized extubation process into two kinds, at risk and low risk. So what category does this patient belong to?
Ma'am, my patient is at risk.
At risk. So in at risk, you have, before you extubate your patient, you see whether the patient qualifies for an extubation or not, whether all the airway risk factors and the general risk factors have been dealt with appropriately or not. I'm not going into the details of extubation. You must know. Okay. So how will you plan now? How will you extubate this patient? Tell me.
Ma'am, I will extubate the patient first. Ma'am, I want that the patient, I will reverse my patient, ma'am, antagonize the neuromuscular blocking agent. After reversing the patient, once my patient is awake, responding to my commands, have adequate respiratory parameters, I will like to extubate the patient over an airway exchange catheter, ma'am.
See, we must remember this, that extubation process is not just simply a reversal of intubation. Actually, if you see, the extubation process is as critical as your intubation, and things are not so much under control as they were during the intubation. So you should actually plan and prepare for extubation as well as you had done for your intubation. Before you should have planned your extubation even before you start your anesthetic process. So as for intubation, for extubation also, you must pre-oxygenate your patient, and you must have help available, expert help available. Remember that even if the surgeon has released the contracture, the mouth opening or the neck extension or flexion does not increase drastically, so that it will be a cakewalk. You will just be able to extubate, and if need arises, you will be able to re-intubate your patient. That is why risk extubation. So you must pre-oxygenate your patient. Then you must optimize all the airway risk factors as well as general risk factors. Do a proper oropharyngeal suctioning, reverse a residual neuromuscular blockade, put a bite block, and on an AEC, you will extubate the trachea of the patient, so that if need be, you can re-intubate your patient soon after, isn't it?
Yes.
Anything else you would like to tell us in extubation? What will you do after still inside, isn't it? The AC remains inside the patient trachea and the tube is over the catheter, isn't it?
Yes, ma'am.
What is the next step you do?
Ma'am, I will oxygenate my patient, ma'am.
Okay, you will keep on oxygenating your patient and you will monitor the vitals and wait for the patient to be more awake, and you will see whether the patient is maintaining his saturation. Similarly, you will monitor your patient in the post-op area also. Suppose at some moment because of some reason your fiber optic fails or patient becomes uncooperative for fiber optic, awake fiber optic. Is there anything else? What will you do? See, you must understand that awake intubation is not synonymous with awake fiber optic, right? We always think that in an awake state, only fibroscopically you can introduce an endotracheal tube. It's not. So in an awake state, all other airway devices can also be used. So what are the other? Suppose this plan fails, what is your plan B? You were talking about some supraglottic device.
I'd like to introduce a supraglottic airway device for this patient, ma'am.
But the problem is that the mouth opening is only 2 centimeters. So do you think any supraglottic device can go through that much of mouth opening?
Ma'am,
yes or no?
LMA Supreme, ma'am, I can try to introduce.
So you can introduce LMS Supreme. You can topicalize the airway of the patient similarly, and you can use LMS Supreme also as your primary device, because the cuff is very thin. It just needs a mouth opening of 13 millimeter. So in your case, LMA Supreme can also be used. Suppose you don't have this option, any other option? Any other option?
Yes, ma'am.
What is your plan C?
Ma'am, ma'am, I will induce my patient with the injection ketamine, and ma'am, I have the surgeons ready. Ask them to release the contracture. After releasing the contracture, ma'am, I'll try to introduce my laryngoscope and then intubate the patient, ma'am.
You make it sound very simple, but things are not that simple. So, what are the problems in using IV ketamine?
Ma'am, IV ketamine is
What are the ketamine? Just tell me what are the advantages? Why have you chosen ketamine? Why not propofol? Why not thiopentone sodium?
Ma'am, because with ketamine, the laryngeal reflexes are not abolished. They stay, ma'am. So that is why I want to use ketamine for this patient. Ma'am, also with the disadvantages of using ketamine is, ma'am, there are auditory or visual hallucinations that are that come with administration of ketamine, ma'am. And there is increased secretion also, but ma'am, we've taken care of that with administration of injection glycopyrrole.
You can always the benefits of ketamine in such a situation are much more than the risk associated, but you should know how to optimally use ketamine. It's not as simple as you make it sound. So the release of contracture mouth opening, that it will allow you to introduce your laryngoscope. Okay, so you must be prepared for that scenario also. Plus, though the contracture is fibrous, you do not expect a lot of bleeding, but sometimes it can cause a lot of bleeding and things can go, quite messy. So do not think that simply giving IV ketamine and release of contracture will be again a cakewalk for you. As far as airway management is there, you must always be ready to maintain the oxygenation and ventilation of the patient. So what is the role of tracheostomy in your case? You had ENT surgeon stand by, for tracheostomy. So what's the role of tracheostomy in your case?
Ma'am, I will only do tracheostomy as a rescue procedure, ma'am. In my case, the landmarks are not appreciable. Also, since the grafting has to be done in that area, so it can result in graft rejection. So I do not want to do a tracheostomy, but only in case of emergency in which I cannot establish a safe airway. Only as a rescue procedure will I consider tracheostomy.
Yes, so tracheostomy in such a case should only be used as a rescue airway management. When you reach, cannot oxygenate, cannot ventilate, cannot tubate management, should tracheostomy be undertaken? Yes. Okay. I think, is my time over? Okay. Okay, we can take the questions. Anything else, Trisha? Okay, one thing more. The final view you had said, what all things can be seen on X-ray neck lateral view? You had said that as one of the investigations.
Yes, ma'am.
What all can
yes,
you see
ma'am,
there?
we can assess various parameters for a difficult airway when we assess the lateral view. In the lateral view, ma'am, we can see the atlanto-occipital distance. If it is less than 3 millimeter, ma'am, then it indicates that it will be a difficult intubation. Ma'am, also atlanto-axial distance. If it is more than 5 millimeter, that means there is this also indicates that this will be a difficult intubation. Apart from that, ma'am, posterior mandible depth, if it is more than 2.5 centimeter, it indicates a difficult airway. If the ratio of the posterior mandible depth to the length of the mandible is more than 3.6 centimeter, it again is going to indicate a difficult airway. Also, the angle between the maxillo-pharyngeal angle is less than 90 degrees. It indicates that the CL grade will be about 3 to 4. So these are the various parameters which can help us to.
So you can take help of X-ray, neck, head and neck, lateral view to, assess your difficulty during laryngoscopy and intubation. What about ultrasonography of the airway? Any use in your patient, ultrasonography?
Ma'am, in my patient, it will not be a very useful parameter because we do not have, because of the contracture, we do not have a lot of area to assess the airway using a USG probe. But ma'am, we can otherwise assess airway parameters and difficulty with ultrasound.
Okay. So for doing ultrasound of the airway, you need the head to be extended. In your patient, because of the fixed flexion deformity, there is hardly any space to keep the probe, isn't it? Plus, because of the thick contracture, you may or may not be able, not a very good option in your case. Yes. Any questions? If somebody
one has asked, ma'am, in case of emergency tracheostomy,
in case of cannot intubate, can you ventilate situation, which technique will be there?
Yes, then the answer, as she already said, that will be a front of neck axis. That's why it will be a difficult case, because identifying the cricothyroid membrane is difficult. So that's why I do a surgical tracheostomy for this patient.
And it says how to manage it if there is a false strike in the percutaneous nasal tracheostomy.
I think that question is out of the purview of this particular case discussion, that whosoever wants, I can discuss separately with him or her.
That's all.
I think you had a session on tracheostomy just prior to this. Any other question?
No.
So I think now Dr. Tina is going to summarize the management.
I'm Dr. Tina Khurana. I'm going to summarize the case. So we have a 28-year-old female ASA grade 1 patient who presented with post-burn contracture over the lower face, neck, and anterior chest since last 2 years. She is posted for neck contracture release and split skin grafting from the lower limb. The main concern in this case is of airway management. A thorough assessment of the airway is absolutely essential for safe airway management. We need to take a focus history, do a physical examination, general and regional. Airway ultrasound or other imaging may be used. This table summarizes the important history which we have to elicit in any case of difficult airway and its important clinical relevance. Like if a patient is age above 55 years, there will be difficulty in mass ventilation. If patient gives history of snoring, there will be difficulty in mass ventilation. If there is restricted neck mobility, then there will be difficulty in mass ventilation as well as intubation. If patient gives history of radiotherapy to the neck, there will be difficulty in laryngoscopy, intubation, surgical access. If patient gives history of chewing pan, gutka, tobacco, there will be submucosal fibrosis and restricted mouth opening. History of epistaxis is important if nasal intubation is to be considered. With patients of diabetes and connective be affected. Now going on to the general physical examination. The first look of the patient, what is the posture, facial asymmetry is there any congenital syndrome, patient is obese, has burns, trauma, or there is a growth in the neck, tumor is there, abscess is there, then the whole airway will be distorted. In patients of acromegaly, there will be macroglossia and prognathism. Presence of hoarseness of voice, stridor, or a previous tracheostomy scar tells regarding tracheal stenosis. Presence of hair in a bun over the occiput prevents extension of the atlanto-occipital joint. Facial piercings also can cause difficulty in mass ventilation and are to be removed. Now coming to the regional airway examination. The tools required for regional airway examination are 2 scales, a measuring tape, torch, wisp of cotton. So the facial appearance is to be seen, and in the nose, any external deformity, deviated nasal septum, fractures, scarring, fibrosis, everything is to be noted. Tests for nasal patency have to be done. The cold spatula test, wisp of cotton test. Then TM joint, we can do the finger test, upper lip bite test, Calder test, interincisor gap. For the oral cavity, you check for oral hygiene, any foreign body, any piercings in the oral cavity. Teeth abnormalities have to be looked for, and they really affect the airway management. In edentulous patient, mass ventilation is difficult. With artificial dentures, we have to note whether they are permanently fixed or movable, and the removable ones are to be removed. Loose teeth need to be identified and extracted or strengthened. Chipped teeth have to be noted. Protruding teeth also make alignment of the axis difficult for laryngoscopy and intubation. Coming to Malampatti grading, and then palate, we note the high arch palate presents difficulty for laryngoscopy and tracheal intubation. Some mandibular space can be measured through the thyromental distance and the hyomental distance. This predicts the difficulty with laryngoscopy and intubation. It determines how easily the laryngeal and pharyngeal axes will align themselves when the AO joint is extended. In the neck, we do an external examination for the tracheostomy site, for tracheal deviation or growth. Length of the neck is measured through the sternomental distance, and circumference of neck is measured. The full normal range of neck movement from full flexion to full extension should be more than 90 degrees. Cervical and AO joint function can be assessed through the 2-scale test or the Delican sign. Extension at the AO joint should be more than 35 degrees. Now coming to the airway examination in our case, first look of the patient, there was a contracture of the neck with a fixed flexion deformity. Bilateral nostrils were patent, right more than left, and there was no deformity. Calder test, upper lip bite test, both grade 2, interincisor gap 2 centimeters. AO joint grade 4, 2-scale test, angle between the scales is 10 degrees. Delican sign, the finger under the chin is lower than finger under the occipital tuberosity. In our case, while analyzing the likely areas of airway management, there is difficult mass ventilation, difficult supraglottic device placement, difficulty in laryngoscopy, difficulty in intubation, difficulty in surgical access, and difficulty in emergence. Only patient consent and cooperation is present. Rest all areas are difficult. So the anesthetic plan for our case would be plan A, awake fiber optic nasal intubation. Plan B, an awake supraglottic device placement through a LMS supreme. Plan C, a neck contracture release under injection ketamine. The investigations for our case would be a complete blood count, urine routine microscopy, serum electrolytes, and a chest X-ray APN lateral view. In pre-operative orders, non-pharmacological means of sedation would be preferred, and we would like to avoid or use minimal dose of anxiolysis as required. In OT preparation, the difficult airway cart it includes different types and sizes of laryngoscope handles and blade, different sizes of endotracheal tubes, oral or nasal airways, specialized ones for fiber optic also are to be included, lignocaine jelly, spray, gargles, stylet, bougie, LMA, supraglottic devices, LMA Supreme, ProSeal, Ideal, whatever is available in each department, Combitube, fiber optic bronchoscope, tracheostomy set, cricothyroidotomy set. Source of oxygen, suction, drugs, defibrillator. So as we mentioned, DAS intubation technique is our plan A. In that we topicalize, sedate, and perform and oxygenate all throughout. For pre-oxygenation, patient, para-oxygenation also providing oxygen attempts to secure. Para-oxygenation is very, very important for this case. We can use nasal and high flow nasal cannula can also be used. Judicious sedation can also be used, like injection midazolam 0.5 mg IV or injection fentanyl 0.5 microgram IV. Dexmedetomidine can also be used in the loading dose of 1 microgram per kg, followed by maintenance dose of 0.2 to 0.5 microgram per kg per hour. Topicalization of the entire airway is to be done. Performing blocks will not be possible in our case due to the fibrous scar tissue. Now coming to topicalization, the anesthesia which will be given for the nasal mucosa, we can do a nasal packing using ribbon gauze soaked in local anesthetic, lignocaine with adrenaline, nasal instillation, nasal spray, nasal gel. Nasal dilatation can be done by using progressively larger size nasopharyngeal airways or lubricated glove finger. Nasal applicators soaked in LA can also be used. Nasal decongestants like oxymetazoline drops, which are used for vasoconstriction and shrinkage of nasal mucosa, are very important. Anesthesia of the tongue or oropharynx, it can be done through gargling, oral lignocaine sprays. Toothpaste method can be used, in which the lignocaine jelly is squeezed in 1 or 2 lines along the length of the tongue. It melts at body temperature and trickles down. Lignocaine jelly can also be put on the lingual surface of the OPA or the tongue depressor. It melts, anesthetizes, and trickles down. Direct spraying can also be done. We have laryngotracheal anesthesia kit, which consists of a curved plastic cannula with multiple perforations attached to a pre-filled syringe, like the magic tracheomucosal atomization device. Indirect laryngoscopy and instillation technique can also be applied. Spray as you go technique, in which we instill 1 ml of 2 to 4% lignocaine along with 9 ml of air through the working channel of the fiber optic bronchoscope. Nebulization. In this, the entire respiratory tract is anesthetized. It is a simple and easy procedure. Delivers particle size about 5 microns. Only thing is, it is time consuming. It takes about 15 minutes. I have listed all the doses according to the weight which are to be used in patients. The total permissible dose of lignocaine for topical anesthesia is 9 mg per kg body weight. Now coming to the choice of muscle relaxant in a chronic burns patient, succinylcholine is to be avoided from 24 to 48 hours post burns till about 2 years post burn. It is avoided due to hyperkalemia. Hyperkalemia occurs due to extensive proliferation of the extrajunctional acetylcholine receptors on the muscle. This can lead to cardiac conduction abnormalities and cardiac arrest. Non-depolarizing muscle relaxants usually become resistant. Hyperemia is another issue. Plasma protein loss is there, the IV fluids. Albumin is reduced and alpha-1 acid glycoprotein is increased. The free fraction of the drug is affected. Now coming to the emergence, we would like to extubate the patient fully awake over an airway exchange catheter, and then patient will be shifted to the ICU for postoperative monitoring. For postoperative pain management, we can use injection paracetamol, injection diclofenac sodium, or tramadol. Thank you everybody for very patient listening. Thank you.
I think there are a few questions in the chat box.
which I can read is, can you explain more about release of potassium? This point. So as you know, whenever a normal muscle depolarizes, the amount of potassium released during depolarization is to the tune of 0.5 millimoles per liter. However, such burn state, when there is proliferation of extrajunctional cholinergic receptors, the amount of potassium release is massive to the tune of maybe 10 millimoles per liter, which can lead to fatal arrhythmias and cardiac arrest. That's why during this period, immediately 24 to 48 hours after sustaining acute burns, till around 2 years, one should avoid use of dexamethasone. Then the next question is, will you not, I can't read it. Any role of nasal decongestion? Yes, of course, we did talk about it. The nasal cavity has to be decongested extremely well by use of oxymetazoline drops. We all know how vascular the nasal cavity is. Then the next question is, will you not give additional analgesic at the time of induction?
Yes, ma'am.
At the time of
Induction.
Yes, of course, you have to give analgesics according to the surgical procedure that is being undertaken. Initially, Dr. Trisha had administered only 20 mics of fentanyl because it was an awake endotracheal intubation. So then once your air is secured properly and you have anesthetized the patient, additional analgesics have to be administered to cover the intraoperative period. Yes, of course.
And the next is
perioperative analgesics.
perioperative analgesics.
Perioperative analgesics, you can give whatever you like according to the surgical. You can use non-sedative analgesics, preferably like your diclofenac NSAIDs, or you can even use tramadol.
That doesn't cause any respiratory depression per se. So there is no contraindication.
That doesn't cause any.
Then what does pre-oxygenation during extubation mean?
Okay. So as you know that during
as for intubation,
you pre-oxygenate your patients so as to increase the oxygen stores of the lungs. You completely fill the FRC of the patient with 100% oxygen to tide over any desaturation which may happen during the apnea period. So similarly, you need to increase your oxygen stores during extubation period. So just prior to giving your reversal or extubating the trachea of the patient, you must take the expired end tidal oxygen to again 0.8 or more than 0.8. So that's how you will increase the oxygen stores during the period immediately after
whether
extubation.
spraying local anesthesia before extubation does not irritate and cause spasm.
We have not advocated spraying. We have not advocated spraying over the laryngeal injury before extubation, because yes, it can precipitate
spasm.
And will you keep jet ventilation ready in case?
And will you keep jet ventilation ready in case of CICV? In this case, as fauna is.
I don't see a rule of jet ventilation. How will you do jet ventilation in this patient? I don't get your question. So I don't get. If I reach this situation, I would have a surgical access which should be done by an ENT specialist, because identifying the cricothyroid membrane is very difficult in this patient.
That's all. Those are the only questions. Yeah.
Okay, thank you. Thank you. Thank you, Dr. Tina. Thank you, Dr. Trisha.
Thank you, ma'am. Thank you so much.
Thank you, ma'am. Thank you for such elaborate case discussion. Thank you, Tina ma'am, for such wonderful compilation about the topic. And so we'll move on with our next session. So for our next session, I would like to invite Dr. Amita Sahani ma'am. Ma'am is professor at VMMC at Safdarjung Hospital, New Delhi, and ma'am's area of keen interest are airway management. We welcome you, ma'am.
Hello, good afternoon. Hello, can you hear me?
Yeah, yes, ma'am.
Okay, okay. So before we move on to the session, you want me to introduce Dr. Nitin?
Yes, ma'am.
Dr. Nitin
Yes,
is
yes,
going to
ma'am.
be our first speaker. Dr. Nitin is going to be our first speaker. His name is Nitin Hairan. Have I pronounced it correctly, Nitin? He is a professor of anesthesia at LHMC, Delhi.